Happy Friday, everybody. For those of you who are watching this YouTube video earlier than anticipated, it's because we're starting earlier than anticipated. And I'm really grateful to both Zachariah and Simi who are co-anchoring the session for a last minute change. I have to cover a colleague at work, and so there were two options, cancel VMR or reschedule, and there's only really one option. And so today is yet another day where we celebrate a senior member, but I think senior doesn't do justice. I think super duper senior, even though Simi will deny this compliment, though she might perceive it as an allegation. She has changed CP solvers in the most wonderful way. And I think many of you, especially those of you who have joined the academy more recently than Simi, will probably associate CP solvers and Simi with the same sentence, with her serving as a bridge to your involvement. And in parallel, in secret, she's been developing her clinical skills so much with joining almost every single rapid fire session. In fact, if she's not there, first question is there a pulse? And and I think that's not unreasonable to think about. So thank you for being the heartbeat of CP solvers, and in your absence, we worry about your very existence, which is a very powerful contribution. So let me hand the mic to you to say hello, and then we'll thank everybody else who's part of this session.
Hi everyone, and Robert, thank you so much for such a kind introduction. And I'm so happy it is recorded, so I get to hear to it again. And I just want to say that if we have an EKG today, please feel free to go ahead and interpret the EKG.
Hi, Captain. Now that you're in the Friday session, not a Thursday session, I think it's customary that we do that. Yes, I'm happy to help you. I think Zachariah's cases have like a 95% chance of having an EKG, including his most recent one, which is quite the case. So yes, we're in for a treat. Zachariah is presenting. But before I hand the mic to him to transition us into the case and an intro, let me thank the people who are making this happen. Starting with Dadmir, who's one of our most recent Academy members, who is scribing today. Mic to you, Dadmir.
Hi everyone, my name is Dogmer, and this is my first time streaming, so hopefully,
Yes.
hopefully it goes well. So,
No doubt about it. No doubt about it. And then Glenn, who's been very busy but made it in the nick of time. Glenn, you're doing teaching points today. Mic to you, my friend.
Hello everyone. Finally, I've managed to come on time. I thought I would be late today. I started to do the teaching points.
Very, very
I
excited
just
to
came
have
back from the hospital.
you. Yeah. Well, thank you for hopping on such last minute. Hopefully, we'll be able to add to a day full of learning. Yeah, the chances of that are very high with Zachariah at the helm. Zachariah, mic to you.
Hi everyone. I hope you're all doing well. Really excited for this case. And earlier this week, Simi said that can I please bring something easy? And I told her that because she's discussing, you shouldn't listen to her modesty. I'll actually have to bring something a little bit more complex for her level. So really excited for this case. And as soon as the whiteboard's up, I'll get going.
Leroy, I was thinking the exact same things. All
Wonderful.
righty. Take it away, my friend.
So the first aliquot is a 20-year-old female that is unable to use her arms and legs. And I'll stop there.
As is usual, see me, we're right in the deep end. Um, Zachariah does not know how to start gently and slowly, which I love. So what are you thinking so far?
Yeah, be definitely a very interesting start. And 20-year-old female makes me think about, is there some genetic vulnerability in this patient or some substances, like we say bad genes or just bad luck? So that's what I'm thinking about, but also wondering if this is more of discomfort, but looks more of dysfunction, and thinking about either this is actual weakness or is this some electrolyte abnormality or something related to central nervous system or a systemic process affecting arm and legs? And we usually see that some autoimmune diseases, they often start with extremities. So that's what I'm thinking about, but excited to learn from you.
I think those of us who have been in CP solvers noticed that you did not say bad behavior, and I commend you for not saying bad behavior. There's no such thing. I just wanted to call attention to that. That was really cool. Um, I'm right there with you. Sorry, I'm mid-bite. I thought you were had some momentum and kept going enough for me to finish this big bite that I took. And you analyzed both the foreground, which is her symptoms, but also who she is. And I think whenever young people have such a serious illness, it really is unusual and unexpected, as we learned and re-emphasized with Rabih's amazing case yesterday. So I think we'll have to answer, why is this horrible thing happening to her? And I'm curious, just to for you to practice next year, I want you to imagine being there and you're hearing that she's saying to you, I can't use my arms and legs. What do you think you would want to know next? And we've been practicing this in the academy of sort of triaging the level of information. So what would be your first few questions for her?
Rabih, I'm curious if this patient presented to us on a wheelchair, or is the patient able to walk or not? And as for the activities, is that that the patient finds it hard to do activities or is unable to do any of the activities involving arms and legs? And you always say when patients cannot eat, walk, and talk, it is worrisome for us. So that's what I would like to ask first. And when did it start? Or if there was some event that the patient associates with it, or anything we can find in history that we might associate with these symptoms.
Superb. I think that's very wise. In your answer, you're triaging the severity of the concern. I can imagine somebody saying, Hi, doc, I cannot use my arms. Look. And you're like, huh? Wait, you can. I can imagine that. But I can also imagine wheelchair, cannot use my arms. And you're trying to get a sense of that. And I think as we try to get a sense of the severity of what she is saying, it's also really important not to lose track of other things that we're assuming. So we're assuming she has a mental status, and we're assuming everything above her neck is working based on what she said so far, but maybe she didn't say it, maybe somebody else brought her in. So I'm curious as you to know, how bad are the things that she has grabbed our attention to, but also how bad are other things we might have overlooked. And there are essentially things above the arms and legs, which is the neck and the face. And there are things in between. And I hate these questions because they're a little bit read my mind questions, but can you think of any other neurological functions between the arms and the legs that are important to try to establish? What do you think?
Yeah, we can think of more of a structural approach because we don't have a lot of information right now. So maybe a muscular problem because muscles in the body would be in arms and legs, but also thinking about any neuromuscular junction disorder or nerves because they would be distributed in both arms and legs. So that's what I'm thinking about, but also a possibility of stroke or something like that, but we don't have signal for that yet.
Yeah, I am. I could tell that the way I was asking you was a little misleading. So I'll just tell you, uh, because you're getting so much momentum, I don't want to derail you. So we hear arms and legs, right? We want to establish, is face involved as well? Is brain involved as well? And the thing that I was trying to get at, and I'll practice how to get it at later just for the sake of time, is between the arms and legs, is the bladder and the bowel. And you want to know, is she able to urinate okay? Is she able to defecate okay? Because it's so easy just to be like, oh my gosh, you can't use your arms and legs. Go, 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 go. But you have to first establish the entire neuroaxis. It'll be very obvious to see if she has anything above her head and neck because you can see it. Facial droop, diplopia, ptosis. It'll stare at you in the face. But of course, her bowel and bladder will not be so evident, and you have to go searching for it. And the way you go searching for it is to establish and try to get a post-void residual, and potentially, if you need to, do a rectal exam to see if there's rectal tone issues or saline anesthesia. So what's this conversation? This conversation is all about when you're entering the deep end, you first have to try to get a sense, well, is it really deep? How severe are the issues that she is saying? But I think you have to assume it's a deep end until you know otherwise. And so when you're in the deep end, it's very tempting to fixate on the things you've heard and assume that they're the only thing that are deep. And when you hear arms and legs go down, I encourage you to take a moment to breathe and say, wait, what about things above them, head and neck? And what about things between them, bowel and bladder, to first crystallize the actual problem rather than get sucked into a vortex of solving the wrong problem. So kudos to you, Simi, and let's see if she's in a wheelchair, if she can talk. um, or we have a much more gentle presentation than I think we're realizing. All right, Zachariah, back to you, my friend. Very intrigued as always.
Yeah, really, really great discussion. And again, quite a short second anecdote. But in terms of the history of presenting illness, she'd been well until about 4 weeks prior, where then she said she started to develop progressive difficulty in her arms, in her legs, just not working. It was a bit difficult to characterize where the weakness started, but she said that she felt it probably was in the legs first and then started in the arms, but she really wasn't sure. And she'd been well. She had no prior preceding illnesses. She had no chest pain or dyspnea. She didn't have any fevers and wasn't losing weight, had no abdominal pain at all. And in terms of her neurological symptoms, she had no headaches, no vision issues. She was eating fine, and she had no bowel or bladder issues. And I'll stop there.
Amazing. That's super interesting, Zachariah. Thank you. So, Seeme, you've got a little bit more information. What happened into your thinking there?
Robin, usually when we have bilateral weakness, we think about spinal cord, but having no bladder or bowel symptoms takes me a little away from that differential. But also having that the symptom first started in legs and then started in arms makes me think about some demyelinating conditions as well. But also thinking about electrolyte abnormalities, but I think that they would not have this specific pattern of starting in the legs and in arms. And Rabih, I'm still curious that how would we link if we have proximal versus distal weakness? How can that help us narrow differentials?
Superb. I'll definitely start reflecting with you, but let me ask you one final question. Is we didn't know the time course, and now we know it's 4 weeks. What about that element for you?
Probably I think if it would be some autoimmune condition, it would not be just for 4 weeks. Usually patient would have on and off symptom for 6 months or so. So 4 weeks makes me think about anything that happened 4 weeks ago, whether it was some infection patient got or any travel the patient had 4 weeks ago. So that's what I'm thinking about.
Yeah, I think if we were to go back and answer all the questions, we were trying to answer the basic questions, which is, are her head um, are her head and bowels involved? Possibly, but no clear signal yet. And the second question was, how bad is what's happening to her arms and legs? And really, almost even more approximately, what is happening to her arms and legs? And I think the answer in my mind is, I don't know. We haven't heard that she's falling or dropping things or whatnot. So let me tell you where I'm at. I'm in a situation where I have taken all this information and put it aside because I don't really know what problem this is. Is this weakness? Is this arthritis or arthralgia? Is this neuromuscular weakness or is this PMR? I don't know. But I know exactly what to do next. Let's talk for a moment about the physical exam. The physical exam for patients with chest or abdominal issues is largely underwhelming. And I say this with a tremendous amount of respect for people who have fine-tuned their skills, but many people who have concerns in their chest or abdomen often need tests well beyond the physical exam. And that's on purpose. The entities that we are trying to discover on a chest and abdomen are very deep, hidden behind the rib cage or hidden behind dense peritoneal tissue. And so you can imagine it's very hard to detect that with your hands, eyes, and ears, and much easier to detect it with imaging that penetrates and bypasses those structures. That is not true for the extremities. It is almost impossible to hide disease in the extremities because there is no thick protective layer between you and core and the disease pathology. So if I were getting this history, I would just automatically do the physical exam in synchrony. And all I will say to you is, in earnest, I have no idea what the issue is. And so I think that as a learner, you're constantly encouraged to try to say, what's the answer to the data in front of you? Step one, step two. You get a stem, what's the answer? A stem, what's the answer? And sometimes in real life, the answer is, well, actually, the correct thing to do here is to realize that the stem and the question you just gave me doesn't allow me to crystallize the issue. And I think that's where we're at here. And I think Zachariah is allowing us to really see how vague a history can be and how often it is sometimes to use different tools to try to get to the root of the problem. And I will tell you that the exam here will define this space because extremity issues don't happen. And so I'm really, really curious to reflect back with you once we get the exam about what were the features of the history that were helpful and what were they distracting. It'll be a good exercise to do that. So, Mike, to you, Zachariah, what do you have next for us?
Superb. And in terms of her past medical history, largely unremarkable. She had just finished school a couple of years prior. She had no remarkable family history, didn't take any medications, and didn't use any illicit substances or drink alcohol at all. In terms of her physical exam, she was relatively well appearing. Vitals were normal. She was afebrile, and she had a normal skin exam. And her cardiovascular, respiratory, and abdominal exams were normal. Neurologically, she was fully alert and oriented. Her cranial nerve exam was normal, and she didn't have any sensory level on physical exam, but she was markedly weak in her arms and her legs. In the upper limbs, I would say distally, so in her hands, there was more weakness than proximally, but throughout the upper limbs, it was between 1 to 3 out of 5, and slightly reversed in the lower limbs, where there was proximal greater than distal weakness. Her sensory exam was also unremarkable. Besides, without a doubt, in her right foot, there was decreased proprioception on repeated testing compared to the left, but no other abnormalities were found. And in terms of her reflexes, they were present, but globally reduced. And one more thing on the past medical history is that she reported that about 4 years prior, the exact same syndrome had occurred that had then sort of self-resolved itself over a few months. And I'll stop there.
Very, very interesting. Seeme, I think the chances of an EKG are very low in this case. Why don't we do this, Seeme? I think we haven't spent enough time as a group dissecting the neuro exam. So I actually think now may be a good time to do breakout rooms to see what progress people can make. And so let's do a 5-minute breakout room and I'll let you collect your thoughts. Don't worry, you're with some very esteemed colleagues, including the case presenter himself. So maybe you can get more intel for us. And I'll see you all in a few minutes, okay? All right, welcome back, everyone. So, Seeme, what did you learn? What thoughts do you have?
Yeah, Rabih, it was nice learning from everyone. And we had Manpriya in our breakout room who joined us for the second time today. And we were just discussing about still having very broad differential at this point. And we were thinking more about that possibility of neuromuscular junction disorder, but we don't have any signature of any dysphagia or any abnormal reflexes for that. But we were also thinking about GPS or any of the variants that is similar to that. That was something Priya mentioned. And yeah, Rabih, we were not able to make a lot of progress. Excited to learn from you.
I think the progress you made at least was to empower Manpriya to turn her video on. Very nice to meet you. Thank you for joining us. It makes a huge difference to be able to see people's faces. Yeah, I think it's hard to recognize. I think I'm right there with you that the range of possibilities is infinite. I think there are some things that we've made much less likely. So, what do you think about the possibility of a brain or spinal cord problem? Do you feel that they're high or low?
Rabih, I think they're low.
Yeah. And what would you say is the reason for that answer, which I agree with?
Probably because we don't have we don't have any bowel or bladder issues,
Yeah.
and then there's no specific upper or motor neuron signs that we think of. We don't have a flavor of that.
Right.
And also we were thinking that I was thinking there would be some muscle tenderness or something like that, and absence of that makes me think that myositis or things like that are less likely.
Yeah, I agree. I think, what you've done is you're saying that the distal and proximal parts of the neuraxis are unlikely. So if we start with the brain, spinal cord, go into the nerves, neuromuscular junction, and muscle, you're saying that both the muscle and the proximal parts of brain and spinal cord are less likely. And I agree with you. I think it's very hard to imagine that the brain has disease in it that is affecting the whole body without affecting cranial nerves or affecting cognition. The spinal cord is a little bit less likely because in order for it to cause both both arms and legs, it has to be cervical or above. And when you have a high cervical lesion, usually by this time we'll have your reflexes be up and will profoundly affect your bowel and bladder. The truth is we don't know for sure if our bowel and bladder are spared because we haven't examined them directly with direct testing, but I think we can assume that they're probably okay. And so, what is the disease? I think the disease is likely involving the nerves, neuromuscular junction, or less likely, the muscles themselves. And so, yeah, I think that how do we make progress here? I think the truth is that we first have to probably develop a little bit of confidence about where the lesion is. Is it in the nerves, the neuromuscular junction, or the muscle? And I think one thing that helps us do that is the EMG. And the EMG can, with a high degree of confidence, tell you if the disease in one of those is in one of those three compartments. And I think in a patient who is this sick, um, the probability of that being a high yield test is extremely high. But I think if we were to try to proceed with probability, whenever you have reduced reflexes and extensive loss like this, that doesn't involve the eyes, the probability of a nerve disease is really high. And I say that because most of the time, muscle diseases will be proximal only and not be proximal and distal, although a CPK will be an easy test to help us make progress. And most neuromuscular junction diseases, 90% of all neuromuscular junction diseases are myasthenia gravis, and they often involve the eyes and the ocular muscles. So if we're trying to make assumptions here, recognizing that the EMG will save us from any faulty assumptions, is muscle unlikely, but pending CPK, unlikely because the reflexes are down and there's distal predominance. Both those things are unusual for muscle. The neuromuscular junction is less likely because it's uncommon, and if most versions of it do not involve, and most versions of it involve the eyes, and the eyes are spared here. So the nerve, and I think whenever you're thinking about the nerve, it's really helpful to realize that nerve diseases, whether or not neurologists vocalize them, nerve diseases come in two flavors. And the two flavors are there's focal nerve disease that is strategically affecting the nerves in a very targeted way, or there is diffuse nerve disease. And I think I'm talking a lot now because I think localizing this issue is going to be very key. So I see Zachariah has rejoined us. Yes, power outage. Thank you for hopping back on. I'll just sort of summarize, just because I think it's always helpful for the case presenter to hear what our thinking is. So Zachariah Seeme was saying that because of the because of the reduced reflexes and the lack of bowel bladder involvement, we're not really running towards the brain and the spinal cord. And we have the nerves, neuromuscular junction, and muscle as our primary focus. The muscle is less likely because the reflexes are down and there's distal weakness, though it's still possible. The neuromuscular junction is less likely because the most common neuromuscular junction disease, myasthenia gravis, often involves the eyes. And so we're fixated on the nerves, realizing that in a patient with such a serious neuropathy, an EMG nerve conduction study is a way to make sure that our localization process is foolproof rather than an educated guess. And so we're really focused on nerves. And I was about to launch into a simplification of nerve disease by emphasizing that nerve disease is either a diffuse process or a strategic focal one. So, see me an example of a diffuse nerve process is a diffuse loss in B12 causing every single nerve in the body to be impacted by its absence. But there are two strategic locations in the body where a focal disease process can cause widespread nerve issues. And the two places are in the spinal cord and actually in the subarachnoid space. So, Seeme, if you have diffuse inflammation of the subarachnoid space, and the subarachnoid space is the location where the nerves exit the spinal cord and go into the peripheral nervous system. So if you have cryptococcal meningitis or cocci-meningitis or a leptomeningeal carcinomatosis and that place is inflamed, you have a strategic focal problem in the subarachnoid space that causes widespread nerve damage. And the clue to that is that patients with subarachnoid disease will often have headaches because the meninges go up into the brain. And they will often actually have bowel and bladder incontinence because the nerves going to the bladder are also affected. The other strategic place where nerves can be diseased is in the plexus, the lumbosacral plexus or the brachial plexus. Now, most of the time, a plexus disease is focal because you injure it with trauma or you injure it with a focal tumor. But there are some diseases, especially diabetes, that can cause panplexopathy or multiple different plexi being affected. Well, those are the two instances where you have a nerve disease where imaging helps you. Most of the time when you have a neuropathy, you don't need to image anything because it's every single nerve in the body. And I encourage you to be open to the possibility that taking a picture of this patient's central nervous system to look for the subarachnoid or the plexus may be a clue, but that's very, very rare. Most of the time when you're dealing with a neuropathy, you're dealing with a widespread issue that's affecting the nerves. And under the realm of a diffuse neuropathy, you'll see that EMGs classify it as an axonal neuropathy, meaning that there's a diffuse process affecting all the axons in the body. It's a demyelinating neuropathy where there's a diffuse neuropathy affecting all the myelin fibers, or there's what's called a mononeuritis multiplex pattern where there's often actually either ischemia to the nerves or an infiltrative process to the nerve. So I've said a lot, but I'll just summarize it by saying this is a peripheral process, most likely the nerves. And within the nerve schema, most likely a diffuse nerve disease rather than a focal one in the subarachnoid space or in the plexus. And a diffuse nerve disease is often broken down by the mechanism axonal demyelinating or mononeuritis multiplex. That mechanism predicts the disease. Most axonal diseases are the effects of substances, be it nutritional deficiencies or toxins like heavy metals. Most demyelinating neuropathies are the result of an immunological phenomenon like AIDP, paraproteins, paranodal antibodies. Most mononeuritis multiplex is a vasculitis. So the EMG and the pattern of neuropathy predicts the mechanism. What will we have to do for this patient, Seeme? She is sick, so we have to ask ourselves, do we need to empirically treat her? And the empiric treatment here is IVIG for Guillain-Barré. So that'll be something that Zachary has to think about. I'm being mindful of time here because we could go on forever. But I want to just take a moment to see, because I've just said a lot. Curious what questions you have about this thought process. What clarifications can I offer you as we move forward?
Rabih, about checking for any B12 level or
Yeah.
zinc or anything like that. Would it be more diffuse or would it be bilateral, or what are your thoughts on that? And how do you think the history of the same episode happening 4 years ago and then self-resolving?
Yeah, I think that, the fact that there's a self-resolving phenotype to this either means that she has periodic exposure to something, like a substance, or that she has an intrinsic vulnerability that's being exposed all the time. So either she has another toxic or nutritional exposure over and over and over again, or that she has an intrinsic vulnerability, and that intrinsic vulnerability may be immunologic, that her immune system gets unhappy periodically, or it's genetic, meaning that she has a genetic phenotype that recurs over and over again. And you see that prior history doesn't help you because every single category of disease is still possible. She could still have a substance disorder. nutritional deficiency or toxin. She could still have an immunological phenomenon or a genetic disease. So that's why I'm not using that history now until we figure out, does she have a substance, either a toxin or nutrition, or does she have an immunological phenomenon? You're seeing, Simi, that the way to make progress in a case like this is the EMG, but also if you assume it's axonal, you're going to do a whole toxin check, B12, copper, zinc, heavy metals. You can send a lot of blood tests looking for substances. If it's an immunological phenomenon, all that you can do is empirically treat for Guillain-Barré with IVIG. At the same time, you can test for antibodies that cause immune phenomenon. And the antibodies are the paraproteins for paraprotein-associated neuropathy, are the ganglioside antibodies for diseases associated with Guillain-Barré and CIDP. And you can also test for rare fancy-smancy antibodies called the paranodal antibodies. That's all you can do. So for the sake of time, let's leave it at that and see what Zachary has in store for us next.
Just a really, really incredible discussion. There are three more aliquots, but the last one is really, really short. In terms of the initial investigative workup, she had a white cell count of 9 with a normal differential. She had an HB of 10 with an MCV of 103 and platelets that were slightly on the lowish side, around 170. Her renal function was fine, liver enzymes were normal, her CRP was normal, her CK was normal. And in terms of her iron studies, the ferritin was moderately elevated at about 450, with a slightly low percentage saturation of 22% and a slightly low transferrin as well, with the iron level being on the low normal range, and her folate was normal. And in terms of an autoimmune workup, the initial ANA was negative and the acetylcholine receptor antibody was also negative. And her glucose was persistently normal throughout, and her thyroid function was also normal. And in terms of initial lumbar puncture, a CSF culture was positive for Enterobacter cloaca, sensitive only to meropenem and tigecycline. And I'll stop there.
Oh, wow, very interesting. All right, Simi, what do you have? What thoughts do you have about this?
Yeah, Rabih, really interesting. Still thinking about possibility of any nutritional deficiency contributing to this, but we do have CSF culture positive for a unique organism I don't have much knowledge about. And I'm not sure if platelets are, usually when we have platelets, we think about ruling out heparin, blast, and schistocytes. So I'm not sure if platelets are low to the level that we think of that, or it is just a response to the infection that is going on. So yeah, Rabih, that's what I'm thinking about.
Your ability to say so much in such little time is incredible. Yeah, I think when somebody has a macrocytic anemia, nutritional deficiencies loom large, especially B12 deficiency. And B12 deficiency can have an impact on your iron, either through pernicious anemia or through impaired iron absorption in hematopoietic cells. I think it's interesting that she has a positive CSF culture, and I'm wondering, is this because she has an infection in her CSF, or is it because the lumbar puncture examiner had Enterobacter cloacae on their gloves as they entered into the CSF space? And the pretest probability of meningitis in this patient is so low that I think I would be inclined to see if this culture is false positive. And your clue might be, of course, her symptoms, but also her CSF white blood cells and inflammatory response. If she had otherwise normal cells, no protein, no glucose that is low, then I would probably call this a contaminant. If not, this is a gram-negative organism, and you would wonder, gosh, why does she have gram-negative organisms in her CSF? And the most common reason for a true gram-negative organism in the CSF is there's some contiguous spread of inflammation from the gut into the spinal cord. And so that would open up the possibility of her having some fistulization between her spinal cord and her gut, which may be a direct fistulization or an indirect one through some sneaky mechanisms. But I think the first step is, what did her CSF profile show? And was it underwhelming or overwhelming? If it's underwhelming, I probably would call this a contaminant. If it's overwhelming, then I think we're asking, wait, does she have a GI/GU/GYN connection, either radiographically or occult connection with her spinal cord? All right, Zachariah, what do you have next for us?
Brilliant. And in the lumbar puncture, the cell counts were all completely zero. So no red blood cells, no lymphocytes, no polyneutrophils, and the glucose was also normal. The protein was normal on the initial LP, as well as the repeat LP done about 3 to 4 weeks after her symptoms had started. And I'll put all the antibodies in the chat from what we do have. But in terms of our autoimmune neurological disease antibodies, everything was negative that we have access to. Minding you that many of the antibodies, like the ones against nodofranvir, we don't have available. In terms of imaging, we didn't have access to an MRI, but a CT spine was done. That was completely normal. And her B12 level was persistently markedly elevated, at least 4 or 5 times more than 1,400. And her anti-parietal cell antibodies were strongly positive, the titer of 1,000, with the titer of 1 to 160. And I'll stop there.
Oh, Zachary, I'm really appreciative of you for giving us all the data as it realistically happened. So, Seeme, maybe we can just first approach one aspect of this case, which is what do you think of the CSF culture findings? And then we can talk about the rest.
Yeah, Rabih, it seems like it was a contaminant because the protein and glucose, they're normal on repeat testing. So I think it was most likely a contaminant, like you mentioned.
Excellent. Yeah, I completely agree with you. I think this is likely a distractor. Perfect. So, and you got the rest of the data. How are you analyzing the rest of the data? What do you think?
Probably it's a little surprising for me because I
Uh,
was thinking B12 would be low, but I'm not sure of how to interpret an elevated B12 level. But the pernicious anemia is something that can be linked to these
mhm.
antibodies we have. So just thinking if we have any association of anemia in these antibodies. So yeah, that's what I'm thinking about.
Excellent. Excellent. You mentioned pernicious anemia. What antibodies do you associate with pernicious anemia?
Probably, I think antiparietal cell antibody,
Yes.
but
There's another one too. Do you happen to
mm,
remember that? Or if not, we'll use this case to remind you probably forever. Uh,
probably I cannot remember right now. I think there are, but I cannot remember right now.
yeah. It's an intrinsic factor antibody. Does that ring a bell? Yeah. And it's very interesting. So, since you are um, entering this same similar space as I am, where you're suspicious of B12 deficiency, you brought it up even with the labs with the macrocytic anemia, and now you have a positive antiparietal antibody that's saying, hey, maybe this person has pernicious anemia, but the B12 level is persistently high. How can you reason through that? How are you, you're like in the court of law and the prosecutor and the defense are both presenting reasonable argument. The defense is saying, hey, the B12 level is normal. But the prosecutor is saying, wait, you have a macrocytic anemia and you have a positive antiparietal antibody. And you, Simi, are the judge. What are you going to do next? Who are you ruling for?
Probably I'll just blame on the patient that maybe there is some substance that the patient is taking, or if the patient is taking extrinsic B12 because maybe sometime in the past a deficiency was found or something like that, but don't have a very good explanation for that.
Yeah. Yeah, it's hard to be the judge, huh? Can you imagine that? Ugh, all the time. Let me help you with one piece of knowledge. So the other antibody associated with pernicious anemia, Simi, is an anti-intrinsic factor antibody. And intrinsic factor binds to B12, and sometimes antibodies to intrinsic factor itself can create a false positive B12. So as the judge, maybe you can come up with a solution. how can you look for B12 deficiency without measuring the B12? Indirectly look for consequences of B12 deficiency. What do you think?
Ravi, I think there's some other levels as well, like methylmalonic acid or things like that for folate and B12 levels. But I'm not sure which one is linked to B12 and which one is linked to folate.
Very good. So both of them are linked to B12, but folate deficiencies also cause homocysteine elevation. So the most specific for B12 is the methylmalonic acid. So excellent. You did a very good job overseeing this case. If I were just to take a moment to summarize, and we have a 20-year-old woman who has a profound neurological syndrome that appears to localize to the peripheral nerves. And we broke down peripheral nervous system diseases into substances or immune. And here, Seeme, we have found a profound set of clues that suggest a substance, macrocytic anemia, and a positive antiparietal cell antibody all paint the picture of possible B12 deficiency. But the defense is saying the B12 level is high. And our counter argument to prosecute B12 deficiency is that it can be falsely high in a patient with intrinsic factor antibodies. So I think next steps would be to get those intrinsic factor antibodies and to measure an MMA. At the same time, you still have to ask, well, why did she have 2 episodes of this? And I think it's really important to remember that patients with pernicious anemia have an ongoing intrinsic vulnerability to get B12 deficient. So what could have happened is either she changed her diet periodically and became more and more vulnerable, or that she periodically uses a toxin, and the toxin that's implicated is whippets. Whippets are a form of recreational nitrous oxide use, and nitrous oxide unfortunately chelates B12. There are many other things that are at play, but we still have to answer, why is this periodically flaring in her? Now we know she might be vulnerable because of her inability to absorb B12. So either she has some dietary issues, some GI issues, or some toxin issues that lead her vulnerable. But I think the first step is to see if we can incriminate B12 as the culprit here. All right, Zachary, I have a mic to you, my friend.
Genuinely brilliant. And I can tell you that we got her to go for an EMG. I don't have the report for her exactly with me, but in terms of her diagnosis, her EMG should have read conduction block with prolonged distal motor latencies and markedly slow conduction velocities, especially in the motor, on the motor side. And in terms of the other workup, went and we talked to her, and I did a lot of research, and it doesn't seem that there's a South African sort of version of whippets or something that's easily accessible, and she definitely hadn't used anything like that prior. And our in the public sector, we don't have access to MMAs, so I spoke to our consultant. I sort of begged her, but she motivated with the clinical manager to make a plan for to pay for it to be done in private. And her anti-intrinsic factor antibodies were negative, and methylmalonic acid was normal. And the next aliquot will reveal the final diagnosis.
Fascinating, fascinating. All right, Judge Seeme, what do you think?
We have prolonged latencies. Doesn't that mean that we have more of a demyelination issue because myelin is required for conduction? So that's what I'm thinking about. And I'm thinking that maybe B12 and this was a trap for us that Zachary laid and I fell for.
Yeah, I think there's the double trap here. I think by a normal MMA essentially excludes B12 deficiency. And the hunt for B12 deficiency was also tempered by the fact that her EMG is more consistent with the demyelinating disease process. And a demyelinating disease process is more evocative of an immune-mediated neuropathy. And immune-mediated neuropathies come in 3 specific flavors: either a para-protein-mediated neuropathy, so a positive SPECT, a para-neoplastic immune neuropathy, or most rarely a paranodal neuropathy, the 3 Ps. Absent that, Seeme, there's a large number of idiopathic immune neuropathies that are given the terms AIDP or CIDP, depending on their duration. Some of those AIDP or CIDP are associated with positive ganglioside antibodies, but many of them are actually occult. This is a very suggestive story of CIDP, chronic immune demyelinating polyradiculopathy, with her having recurrent episodes in the past, high frequency of recurrence. And so I think what would the next step be? The next step would be a combination of immunosuppression with IVIG and or steroids. If she improves, the diagnosis is reinforced. If she doesn't improve, then I think you might have to revisit whether she has a more aggressive form of immune-mediated neuropathy mediated by B cells, which would require rituximab, and that's the category of the paranodal antibodies. But I think in her response to treatment with gentle immunosuppression with IVIG and steroids would probably be the next step I would do. All right, for the sake of time, why don't we hand the mic to you, Zachary, to enlighten us?
So we started her on IVIG, and she wasn't really improving after a few days. So we discussed with neurology, who recommended that we pulse her with IV with prednisolone. And slowly over the next few weeks, she started to improve. And with that, the presumed diagnosis from neurology is that she most likely has motor predominance IDP with recurrence. And just in terms of, I did multiple SPEPs with immunofixation that the results were always rejected, and we never got that. But just because she did actually start to improve with sort of basic immunosuppression, the neurologist felt that that was most likely the final diagnosis.
Zachary, this is an unreal case. I'd be really curious to hear your reflections, but I'm wondering how it felt, Seeme. What are your thoughts and reflections on this case?
Rabih, I just want to thank Zakria for sharing such a wonderful case with us despite the power outage he had. And thank you, Rabih, for guiding me through all the steps in the case. And just thank you, everyone, for joining us. And so happy no EKGs today.
What do you think you learned from it, Seeme? What was new to you? What are you better off from doing this case?
Rabih, the point about false elevation of B12 was new for me, but also I really liked the division of axonal versus demyelinating and how we can divide them into further categories.
Yeah, awesome. Yeah, I think those are 2 really important things to take away from this case for sure. What about you, Zachariah? What was this experience like?
Yeah, it was quite a long journey, and I think at that time we'd learned about these nodopathies and these intriguing paraprotein associated neuropathies, and I was really sort of hunting down that route. And the fact that she persistently had this normal CSF protein, along with the fact that motor predominance IDP is extremely rare, and then the interesting stuff with regards to B12 made me wonder if it was something else. So I really learned a lot from it. But I think what I wanted to say to all those that aren't yet part of our academy or haven't presented a case is that we've been having many internal discussions about how we want more sort of relatively common diagnoses to come about, because at the end of the day, we are just trying to learn the basics about physical exam, normal neurological workups, understanding lab tests. We're not here to learn about just esoteric diagnoses. And yes, I presented a sort of a rare diagnosis right now, but I could have presented a classic GBS, classic diabetic neuropathy, and this exact same discussion would have occurred. So VMR isn't really a place just for rare diagnoses, and I highly encourage you, if you haven't presented a case or feel nervous, to consider doing it. I can tell you that I only have one regret with clinical problem solvers, and that's that I listened for 3 years in the background and only started presenting cases a couple of years ago. And I just should have started sooner because it's been so incredible for my growth. So you're always welcome and join us.
I hope I did justice to your spiel with the background visuals I'm illustrating here. But yeah, this is how you can do it. And for those of you who are on the fence, I will tell you, you will make my year if you present a case of bronchitis on Thursday VMR or Friday VMR. I look forward to it already. So as I mentioned to Zachary and Simi, unfortunately, I have to run to work. 2 minutes behind already. So Glenn, I'll have to check out your teaching points afterwards. And if it's okay, Zachary, maybe I'll make you the esteemed host so you can end the session at the end. Is that okay?
Wonderful.
All right. Thank you all so much for a wonderful hour, and a big shout out to Adadmer for getting your first scribing under the belt. And Glenn, I'll see you on YouTube.
Thank you, Dadimir, for a wonderful case presentation. So I'll be going through the teaching points. So we started off with a presentation of bilateral limb weakness. Wanted to know whether it's just a discomfort or weakness, true weakness, and a sort of substance use, autoimmune disorders, stroke, neuromuscular junction. Had a lot of differentials at this point. Then went on to key questions to ask in history. So wanted to know the severity of the weakness, whether the patient is in a wheelchair, is able to talk on all other clues for severity of the illness, and able to urinate, to defecate, just to know whether we are dealing, well, we're solving the right problem or not. Then to the second aliquot, we learned that it was subacute. So we then thought about travel history, infections, and for the exam findings, they showed more of a lower motor neuron findings. So the spinal cord and brain abnormalities were less likely due to low reflexes, so reduced perception and all that. Those are lower motor neuron findings. And then we thought of GBS, neuromuscular junction as well. And we wanted to have the EMG to help classify the problem. Is it muscle? Is it neuromuscular junction? Is it the nerve? But the muscle was unlikely because of the lower motor neuron findings and the fact that it's mostly distal. Neuromuscular junction was unlikely as well because the most common one is myasthenia gravis and usually has eye symptoms. So clearly ruled it out. Then I focused on the nerve issues. So the ones that can give focal abnormalities is subarachnoid disease, and in this case, most likely diffuse rather than focal, and can then classify it into axonal and demyelinating. Axonal is mostly due to substances. I wanted a workup for substance like B12, copper, and for demyelinating could be immune abnormalities like GBS. Then we gone to the next aliquot about which talked about macrocytic anemia. So here we're thinking of vitamin B12 deficiency. Talked about the CSF culture as well. We thought it could be real or contaminated. We confirmed with the other CSF chemistry findings, the normal proteins and other CSF labs like glucose and all that. So it is we then decided that it's most likely contaminant. Then we thought of pernicious anemia because of the positive anti parietal cell antibodies, but we didn't have anti-intrinsic factor antibodies. The B12 levels were high. But then we learned from Rabih that anti-intrinsic factor antibodies can lead to false positive vitamin B12 levels. So in that case, we wanted to confirm with symptoms and MMA levels. And then after the MMA levels then came out to be normal, we ruled out pernicious anemia and vitamin B12 deficiency. And then we wanted to know why is it subacute, sort of the diet, or could be taking any substances. Then we analyzed the EMG findings, which diagnosed CIDP. So it's a wonderful case presentation, Zakaria, and thanks Dedemir for scribing. Thanks Sim for great discussion, and Rabih for amazing teaching points. Thank you, everyone.
Yeah, brilliant, Glenn. Well done. You covered everything so thoroughly. Really appreciate the amazing discussion, Seeme, and have a wonderful weekend, friends. Thanks. Bye-bye.